We want to ask Dr. Fry and Dr. Clark to come up and for Dr. McCrae to join them at the table, and we have an opportunity for some questions and dialogue with the whole crew here. So do we have microphones that we can pass around there? Yeah, I think that'll work. Sure. Thank you. So we have some mics here at I think at 4 places, so please come up to the microphone and ask questions.
Okay. Good morning. I don't think this is on. Anyway, my question is for Dr. Clark. You talked a little bit about etiology of beliefs. What about, is there any relationship between media defining, particularly women, norms and social anxiety? My question.
So the question was, is there any relationship between media defining norms and social anxiety? Well, yes. So, I mean, one of the key problems in social anxiety is people having particularly high standards for what they consider to be appropriate social performance in order to be accepted. And those standards come from lots of different sources, and the media is certainly one of them. And, you know, one of the things you attack in therapy is those standards. You know, many people have the idea that in order to be accepted, you know, social interaction, you have to perform in some way. Whereas, you know, most sort of casual social interactions are really the human equivalent of two chimpanzees sitting next to each other on a branch and picking nits off each other. Now, we know that that is biologically an incredibly important event. We know that when they pick the nits off each other, they release endorphins and it produces close bonding. But thankfully, you know, we have showers and we also can speak. So we don't need to do that. But a lot of social interactions are really essentially similar. They're just being with people, shooting the breeze. They don't really depend on performance. And that's one of the key things that people learn through the therapy.
Yes, we have a question over here.
This is also for Dr. Clark. Since social anxiety disorder is so prevalent, as a family doctor who's seeing people from birth on, what can we do to help prevent it? Would things like recommending involvement in local community theater where they're getting up on the stage in front of people help them to not have as much social anxiety disorder, or is there something else that you would suggest?
Yeah, great. So the first thing I'd say is identify it, actually. So each year I have my sort of most depressing research study. And in 2016, the most depressing research study was the publication of the English National Household Survey of Psychiatric Problems. We interview a random sample of the population every 7 years, and we look, you know, who's got a mental health problem, what it is, and things. And for the first time ever in 2016, we also asked the question, when we fed back to the person, you know, what the condition was that had been detected by the interviewers, has anyone ever spotted this in you? Has anyone ever commented on it before? And of course, it's largely primary care doctors that are doing this. And what we find is that just as here, our primary care doctors are encouraged to use the PHQ-9, and 70% of people who are depressed in the community, their doctor had said they were depressed at some time in their life. Really good news. If they had social anxiety disorder, which is a much more chronic disorder, would have been present and potentially observable in primary care for much longer, 7% had been detected. However, among the people with social anxiety disorder, 84% had been diagnosed with depression at some stage. So what was happening was that the doctors were picking up from the PHQ distress, but they were really picking up secondary distress because people were demoralized because their life wasn't progressing because of the social anxiety, which was going undetected. And this is actually true of other anxiety disorders as well. You get the same figures for OCD and for PTSD. So I think that's the first issue because, you know, once it's detected, there are really good treatments. But the second thing is, yes, I mean, there's lots of ways that you could potentially inoculate people, couldn't you? And quite a lot of it is against this sort of performance culture, and a lot we can do in schools for that as well. And you know, one of the problems we have in England, I don't know whether it's true in the US, is that we spend very little time in schools teaching people about emotional issues and emotional development. And yet, that is one of the biggest determinants of how the rest of your life progresses. So it really is extraordinary that in England, we focus very much on maths and English and things like that, but very little on emotional development. And I think that's where there could be a great help. And there are some pioneering programs developed here. There's a Penn Resilience program that Marty Seligman used and things, which have very useful effects in schools. So I would certainly want to work much more on that. And in general, I think these problems are easier to treat in children. One of the wonderful things about charters is great plasticity. Of course, it means that adolescents can get incredibly distressed by things going wrong and things can spiral down. But it also means that a good psychological input can have a much bigger effect than I think it can have later in adulthood where things have become ingrained. And that's the work we've started to do with adolescents and social anxiety. I'm stunned at how much improvement that you can get in such a relatively short period of time. So there's a real window of opportunity for us. But we need to work more in terms of our school programs and have a more rounded education system, I think.
Yes, we have a question.
Yeah, it's actually two questions. In the spirit of prevention, I wondered if Dr. Fry could think about biomarkers or other sort of indicators in how they may be used in the future for preventing illness. And is there a slippery slope for early identification of risk in terms of stigma or things like that?
So the question is, could a biomarker be developed for primary prevention, meaning that we have, for example, a young person by virtue of having a father with bipolar disorder on lithium and a mother with bipolar disorder on Tegretol, could we actually develop a biomarker for them to prevent first symptoms from ever developing? I think that's going to be really hard for a couple different reasons. Those types of prevention studies from a design perspective are very complicated and they're very expensive because we would need to really show that we're following someone for a long enough period of time where they are getting out of the risk of illness development. Does that make sense?
Yes.
So the concept's very clear, but I think primary prevention will be difficult in complex neuropsychiatric illnesses. I think secondary prevention, after an episode, we try to prevent further illness progression, which is really where the illness disability comes. I think that's very smart. Before any of our biomarker research, I've been incredibly impressed with parents with mood disorders and how they can monitor their children and will identify, I've got 3 kids, but something about Billy is reminding me about when I was young. And so I think that ability for a parent to observe symptoms, I think is really critical. And I'd like to see more work and research that goes into an aggressive intervention at the first fluttering of an illness, as opposed to meeting syndromal criteria and then making an intervention. I think that's where we will be very successful. I'm not aware of a biomarker that is associated with that flutter, but maybe, for example, you saw if we have these candidate disease risk genes, maybe we look at a group of people who have those and just really follow more carefully than we would otherwise, and at the first sign of fluttering, we intervene.
Thank you. Second question for Dr. Wright, in terms of collaborative care models. I know that you mentioned the co-location model. What are your thoughts about comparing that to more like an integrated care model?
Right, great point. So right now we're kind of at the infancy, so we just
Could you use the microphone there so we can pick it up? Good, thanks.
Excuse me, sorry. So the question was about kind of collaborative care versus integrated behavioral health, right? So
Co-location implies sort of we both do
our own thing, but in the same location.
integrated, maybe
Right.
one consultant or
Right, absolutely. Well, I think the data really suggests using the collaborative model where you're actually interacting with your co-located behavioral health specialists, which makes a lot more sense, right? So I think that in UVM, we're at in the infancy of kind of adopting the collaborative care model. And so even though we've got the co-location happening, we're not always talking. So we're doing a pilot at our Milton site, which is kind of one of those rural sites that I mentioned, where we're having a weekly case conference where we bring everybody to the table to talk about challenging cases. And we try to have an open door policy, but it's hard, right? Because if you're with a client and you have the door closed, we don't want to intercede upon that as a primary care physician. And as the family docs know in the office, or in the audience, it's really, we may not have the time to try to catch you. So it's time. It's trying to find the time and build that into our schedules to be able to make sure that we're having adequate communication and perhaps that supervision that the collaborative care models really rely upon, where there's supervision by a specialist in behavioral health to help guide the guideline-based care for the primary care physician. So,
I just had a question for the audience. Are any of you working here in Louisville or this region in a true integrative care model with primary care and psychiatry? Great. Where are you working?
Family health centers.
Great. Other people? At the VA. Wonderful. Pediatrics, good. Yeah. Yes. Great. So we're starting to see some movement here. I have to confess that in the adult side of primary care and psychiatry at the U of L, we're not really there yet. I think you're way ahead of us with your work at the University of Vermont. We'd like to get there. I would share that we are doing a study that's supported by the NIH to look at delivering treatment for depression using a computer program plus support from a human being. And we're doing that in internal medicine and family medicine here in Louisville and in Glasgow, Kentucky, to look at a rural site. And we're nearing the end of that study, so we should have some results fairly soon. It looks to be going quite well. And it uses a model where the patient does a lot of this work on their own whenever they want to do it at their own time, but then they have a therapist who talks with them weekly by phone. So they don't have to actually even come into the clinic. So it gets past one of those barriers of transportation and scheduling and getting babysitters or whatever it might be to be able to manage that kind of a thing. So we're hoping that that'll pay off and we'll be able to move toward a more integrative model. So some other questions? Yes, here we come. Dr. Thomas.
Dr. Fry, the FDA has warned us to not use genetic tests to determine medication, that there's been no evidence established that DNA variations have an effect on antidepressant effect. So what do you think of these companies coming out and charging people $330 to do a genetic test when there's not been clear evidence?
So this is a landscape that is complicated and it is changing quickly. And the reason I emphasize the FDA warning labels, in my mind, that really highlights two different thresholds. When we are talking about drug safety, we do not, and we're going on FDA guidelines, we're not needing to show efficacy. Safety is a different outcome measure, and I think it is appropriate to be alerting about potential safety concerns at an earlier time point. That's why we see all these warning label revisions that are highlighting if you have this genetic variation and you are Han Chinese and getting started on carbamazepine, this is the wrong way to go. Your likelihood of a life-threatening rash is very high. I think the rash data is I think people understand that a little bit more than the QT prolongation. But if you read those warning labels for QT prolongation, it's asking us to be clinicians and assessing all risk. So that could be someone that has electrolyte disturbances. That could be someone that has a family history of sudden death. That could be someone who is on Prozac at a high dose and is a 2D6 poor metabolizer. We need to establish all risk factors and give recommendations for our patients. So I'm very comfortable with where genetic variation is from the standpoint of alerting to potential safety concerns. There is a second discussion about the rates and the relative efficacy of these trials, and I think you're correct. The evidence base for showing that the platforms can distinguish remission versus non-remission is not to the level of evidence base that we typically look for when investigating drug therapies. I think we need to better understand that the thresholds may need to be different if we're looking at a drug versus a companion diagnostic or platform to assess. So I agree with you. But I think we're going to see that when we individualize care for patients, that there will be value for some, and we've got to figure out a better mechanism to figure out which patients those are. So I'm aware of a very large study that has been presented at national meetings but is not yet published, and really looked at, I think 1,000 patients got randomized to the clinician having that information about the genetic information about how medicines were metabolized versus not. And the primary outcome measure was not met. Absolutely, positively was not met. But a secondary analysis looked at a very interesting question and said, if the clinician sort of made an antidepressant recommendation that was in line with the genetic test results, how did that patient group do versus when that clinician did not make a recommendation based on the genetic information? It's a different question. It was not the primary outcome measure of the paper, and when they analyzed the data that way, when the medication aligned with the data, that patient group did better than the patient group that did not have the medicine prescribed that aligned with their biological information. So I think your point is valid. I think we have a lot more to think about in the context of these types of studies. We're analyzing data at our own institution that is looking at that genetic information. What is the patient expectation as to what they want those types of tests to provide? And how is it changing clinician behavior, if at all? We've heard very important points about a lot of variables go into choosing what types of treatments people might have that might be related to a copayment, that might be related to patient choice, that might be related to clinical experience. Those sorts of variables we have to better account and think about in the context of how these types of platforms come forward.
But I think people are changing medications based solely on the genetic tests that we have now without real data to support changing the regimen.
And I would add that that's not using the test correctly. So we will have patients come into our clinic and say, can you take a sample of my saliva and I want you to tell me which one of these antidepressants is going to make me feel better. This is an enormous responsibility for the clinician to really say, here's what this type of information can provide for us, and here's how we might find some of the data actionable or assuring. But we have to really acknowledge there are limitations to what this can provide. I think what you're describing is what we don't want to happen with any biomarker. Biomarkers are not meant to replace a good clinical examination and an interaction with a patient. We want these new tools to be tools that are used as an adjunct to an evaluation.
Totally agree.
Thank you very much. We'll have one more question, and then I'm going to ask the last question as a prerogative of the chair. We have one out here, yes.
I have a question to Dr. Fry. So I'm a second-year psychiatry resident. I have noticed that it is not uncommon to see patients with multiple mental illness, diagnosed with multiple mental illness, like bipolar plus schizophrenia plus schizoaffective disorders, blah, blah, blah. So I was wondering if you have any resources about like biomarkers to help providers to diagnose patients. Like if it is possible in the future, we will have blood tests and then we will say this patient most likely have bipolar disorder.
So I appreciate your question because you're really asking about biomarkers when people have multiple health problems, which is the average sort of patient that we work with every day. And I would underscore the limitations of the talk that I gave today, because those are really designs that are looking at what is the biological signature of bipolar disorder or someone who gets manic when exposed to an antidepressant. The research methodology has to be very narrow in scope with these early works, but you're highlighting quite importantly, I might add, that we have to take this in the context of that patient. So for example, we know that when people are drinking and they have bipolar depression, that alcohol in and of itself is a risk factor for a switch. We know that if people are depressed and they have subclinical hyperthyroidism, that is similarly a risk factor for switching when on antidepressant therapy. So we have to take into account all these other variables that are a typical patient seeking health care. Same thing with a biomarker for diagnosis. We see bipolar disorder highly comorbid with social anxiety disorder, and when the two of them are together, alcohol is right around the corner. The biomarker methodology right now does not address that and will have to be taken into account if these are going to have the clinical value that we hope.
Thank you.
Thank you. The last question is for me, and I'm fascinated with this whole development of precision medicine, but most of my career has been in developing and testing psychotherapies or psychosocial treatments, and I'm wondering what the panel knows or could suggest about whether we're getting anywhere where we could help predict which treatments, psychotherapy, a type of psychotherapy, or a certain kind of pharmacotherapy might be the best choices for a given patient, or maybe a combination of those. There's a microphone there for you, Dave.
So I started life as a chemist, and that was my first degree at Oxford. And I did chemistry because I was interested in drug treatments for mental health. But at the time, the problem was that it was clear that they were sort of a very blunt instrument because you got all these side effects that we've been talking about. And they didn't seem to be precision medicine to me. And it was wonderful to hear Mark's talk today and how biomarkers and things may well help us finesse some of those side effects, which is great. And I would have loved to have heard that as a chemist. So I switched to psychology because it seemed to me this was precision intervention, because you're not looking at treating a particular syndrome with a particular intervention. You're looking at very tightly individualizing the treatment on particular beliefs and particular experiences. And when you look at some of the treatments we've got, so for example, the internet treatment I was showing briefly in my keynote, in that trial we had over 100 patients going through it. Not a single patient had the same intervention. So the internet treatment has multiple modules which focus on different beliefs, whether it's a fear of shaking, a fear of trembling, a fear of sounding boring, feeling too responsible for others' enjoyment. And when we tracked it, and the therapist releases these depending on the particular belief profiles that patients have, and when we tracked it through, no single patient had the same sequence of modules. So these things can be very precise interventions. But of course, they're not always in practice like that. So there is this sort of thing of publishing lots of manuals, which are like cookbooks. And people think it's session 3 and we do this, and it's session 5 and we do that. And that's really a travesty. That's not really what these psychological therapies are there for. And they're not going to really produce the precise results without having this very good formulation and then targeting things on these particular targets within the clinical conditions.
So already we have a psychosocial treatment that is precision medicine in a way, but I'm wanting to drill down on let's say Dr. McCrae has a patient in her office that's significantly depressed, and she's trying to think whether it's best to just do a blanket approach of, this person should be on an SSRI, should go to cognitive behavior therapy, should start exercise, and should be on a diet, and who knows what else, or whether we're at the point where we could say this person would do better with cognitive behavior therapy than escitalopram. Is there any evidence that's pointing us in that direction?
So your question makes me go back to my days when I was a resident and a chief resident with Lou Baxter, who was very interested in the neurobiology of OCD, and he had a study that showed that successful patients who struggled with OCD and who did well with clomipramine actually had the same brain change, which was a bilateral subcortical hypermetabolism that got less hypermetabolic, that it looked exactly the same as OCD patients who responded to a psychotherapeutic intervention of exposure response prevention, or ERP. So in my mind, the intervention probably is less relevant, but it's what the change is that has been associated with improvement. And I would agree with Dr. Clark. I think some of the precision narrative now should really be reinvigorating for a lot of our psychological interventions and better understand target symptoms and what might be corresponding that way. I am aware of the Emory group that has really looked at baseline imaging predictions that distinguish doing well with cognitive behavioral therapy versus a medication. I think part of this, ultimately, that we don't measure very well, and kind of gets to this earlier question, is patients are coming into an intervention with an opinion, with ideas, and with expectations. And we may find that, and I think all of us have patients like this quite regularly, where they're clever, they're intuitive, they're very interactive, and they're going to be really interested in more of a psychological intervention, where some patients don't have that interest or ability and are going to be far more interested in pharmacotherapy. I think all of our precision medicine narratives thus far haven't taken that into an account in a way that I think we really should, and I think that would prove to be very interesting and likely very helpful.
Yeah, I wonder if we'll ever get to the point where it's a little different than it is now. I mean, if a person comes to a psychotherapist who's not a prescriber, I would imagine that the main treatment they would think of using would be a psychotherapy. Maybe they would recommend that they see a primary care doctor or something to get medication also. But there may be choices that are made based on what the clinician's training and background is and their particular interests, without considering necessarily what may be the very best for the patient. So I think we can do that probably today, even with what we know clinically, but I hope that we'll get to the point where we don't have to do a brain scan to figure out whether they do better with CBT than medication. There might be some other things that would help us.
I mean, Mark, though, is highlighting a very important point, and one where there is a fair amount of evidence, at least for differential response between medication and psychological treatments in depression, and that's patient preference.
Yes.
So, we have a number of trials where, some people are randomized to the psychological treatment or the medication, and some people are given their preference. And you find that if someone has a strong preference for medication and they're given that preference, they do better than if they were given psychological treatment, and vice versa. So that's a straightforward one. And, I think one of the lessons from that for us all is that patients need to have choice, and that's really critical for their healthcare. Of course, what might be the mechanism? Well, in psychological treatments, there's a long literature assessing patients' views of how credible a different treatment is. And we know in many trials that the more credible someone thinks a treatment is, the more likely they are to respond. And that's for drug treatments as well as psychological treatments. In one of our panic trials, where we compared cognitive therapy with imipramine, we found that the credibility of the imipramine treatment predicted outcome, even when you control for plasma level of the imipramine. So, this is a key variable in all types of treatments. The literature in terms of differential response to different psychological treatments is not so strong. We don't have the same findings that we have for medication versus psychological treatments. But it is undoubtedly the case that we find there are some patients who come in and they say, I really want psychodynamic therapy for my depression, and some people say they want CBT. And because of this general literature, the IAP program at least tries to give them that choice when both are indicated by NICE.
Thank you. Well, thank you, audience, for hanging in there so I could ask my questions answered. And it's time for lunch now. Remember to sign up for your workshops, and thank you to our panel members.